Okay, well, thank you, Carol, for inviting me to discuss Sudep. I'm going to encourage people to save up questions at the end because it's a complex topic and somewhat frightening. We're going to talk about what it means, what causes it, and how to manage or prevent it. So, oh yeah, there we go. So I'm actually, this is going through a remote computer. So it's kind of slow. Okay, here we are. So Sudep is something that happens generally in patients with severe epilepsy, which I'm sure some of you have. And severe epilepsy per se is, as you very well know, not a nice thing. Often associated with low academic and job performance, memory loss, impaired psychosocial skills, depression, multiple drug side effects, and lastly, increased risk of death, including Sudep and suicide. So, what causes death in epilepsy? Well, as you certainly, sudden unexpected death in epilepsy, which I'll discuss in greater detail, is the number one cause of death in epilepsy. Status epilepticus, drowning, motor vehicle accidents, falls, burns, and other seizure-related accidents are also certainly there, but Sudep is actually the number one cause. Then there are deaths due to acute symptomatic seizures with or without status epilepticus. So these are side effects of the seizure, and there's deaths indirectly due to epilepsy, such as someone's in status epilepticus, they have aspiration, pneumonia. Unfortunately, suicide is more common in people with epilepsy than in not people without epilepsy, and cardiac disease can be exacerbated. So what we're concerned about is what happens with death due to directly having seizures. So increased mortality in people with epilepsy is basically the same thing. Seizures are the most common cause, absolutely, and there's a 27-fold increase of sudden death in epilepsy. And in the United States, Sudep is the leading cause of lost years of life after stroke. So it's a pretty serious business for the whole community. Efforts to assess and prevent epilepsy-related deaths remain inadequate. Now, we may be able to reduce the risk of epilepsy-related deaths through education, improved medical adherence, such as taking your medication as prescribed, and addressing mental health conditions. This is all very critical and lots of work to be done. So what is Sudep? Sudep is defined as sudden, unexpected, witnessed or unwitnessed, non-traumatic, and non-drowning death occurs in benign circumstances in an individual with epilepsy with or without evidence for a seizure. So what it means is it happens often, if not mainly, in sleep. It happens often when people are by themselves in bed, they have a generalized seizure and they stop breathing, and then the heart stops. That's the most common occurrence for this. And the medical world does not find any other cause that explains this death. This is excluding status epilepticus. And as I said, our postmortem examinations do not reveal a cause of death. Okay, so as a clinician, this is something that is hanging over my head as well as patients' heads. It's a nightmare. It's a nightmare for the family and the caregivers. I've had several calls from a spouse or a parent indicating that someone had died. They found them dead in bed, which is very distressing. Fortunately, it's rare, but not rare enough. It occurs in 7 to 17% of deaths in people with epilepsy. Happens more in males, mostly patients aged 20 to 40. And we think it's caused by stopping breathing, usually when you're asleep, and then you get a cardiac arrhythmia, or it stops and you get you get swelling of the lungs because the heart's not pumping, and you die. Excessive alcohol consumption can be a major contributing factor. So as I said, it's most common in younger people. It's associated with generalized tonic-clonic seizures more often than other types of seizures. Most often occurs in bed during sleep, and often patients are found in the prone position, sleeping on the stomach, and usually the person's in bed alone. I'll give you a little side story here. They did a study of children with epilepsy who go to public school in England, which means private school. So they sleep over in these public schools, several students per room, and they have epilepsy. And if the kid's going to die from Sudep, it's usually at home with his parents when he's in bed in a room by himself in his parents' place, as opposed to being in a situation where there's lots of kids around sleeping. So something about the brain realizing that there are other people around that helps prevent Sudep. As I said, typically you get a seizure followed by cessation of breathing called apnea, and then you get a slowed heart rate, and then you get asystole or cardiac arrest and death. We think that a crucial element of Sudep is dysfunction of the brainstem, which we'll go into in a little bit of detail. And there's some biochemical abnormalities which can probably contribute to Sudep, certainly in animal models, which of course we can address in human pharmacology. The value of nocturnal monitoring to detect seizures and post-ictal stimulation is unproven but warrants further study, and I'll discuss this a bit later. So maybe we can stick an electrode or two on a person's head who's at risk for Sudep and monitor them and hopefully predict when a seizure would happen and give some type of feedback to prevent Sudep. So this is what people are working on at present, including my lab. So the epidemiology is interesting. It's much more common in people with refractory epilepsy, and even more common in people who are referred for surgery or vagal nerve stimulation. That doesn't mean you don't do that, because surgery and vagal nerve stimulation often are thought to prevent Sudep, but not 100%. And in the age range we've talked about already, between the age of 21 and 50. So this group of ages, I won't go into that again. Medical and psychiatric comorbid conditions. These are many of the common comorbid positions for epilepsy in general, but for Sudep, we're particularly concerned about mental health issues, which can seem to predispose to Sudep, as well as traumatic brain injury. And you can see alcohol abuse or use is another problem. So certainly if you have bad epilepsy, you're poorly controlled, you're sleeping alone at night, you're at increased risk for Sudep. However, and other problems, you don't have someone monitoring you in your sleep or sleeping with you, and of course not taking your seizure medication. But Sudep can occur in patients with recent onset of epilepsy, well-controlled or benign epilepsy. So it can even affect people who have very minimal epilepsy syndrome, which is not nice. Also, some Sudeps occur without a preceding evidence of a seizure, which again, we don't understand at all. Now, Jorge Brunio, who's the head of the epilepsy unit in London, Ontario, did an editorial about Sudep because I must admit, when I first got into the epilepsy game, I did not tell my patients about Sudep because I was embarrassed to tell them that they might die, and I was afraid of the consequence. I didn't want to upset the patient. But I now tell everybody about Sudep because patients want to know about their risks, families want to know, and they're very upset if they don't know, and suddenly they find an epileptic family member dead in bed. As I said, though, Sudep does not occur only in those with severe or catastrophic forms of epilepsy or those whose seizures are difficult to control. It can occur to anybody. So I think we all have to think about it, and we have to learn how to deal with it better. Many of the patients in a registry died during the daytime, and despite receiving cardiopulmonary resuscitation. This finding indicates that perhaps the mechanisms causing Sudep are not just related to an obstruction of the airways, but are more likely a cardiorespiratory or more complicated phenomena. Again, this means we need to do ongoing research to understand it better. But the important take-home message that Dr. Brunio said is that from now on, clinicians should start conversations about SUDEP with their patients with epilepsy earlier rather than later. There are many unknowns about SUDEP, and we do not talk about it with our patients, likely because of the lack of knowledge about the mechanism causing this condition or the risk factors associated with it. But I think I'm sure that most patients want to know about this risk. Practice guidelines now is that we should tell people about SUDEP. This is the risk, but the major risk, as I said before, is generalized seizures, as opposed to just having focal aware or unaware seizures or complex partial seizures, as it said in the past. Okay, so we need to know what the mechanisms are for SUDEP so that we can design prevention strategies. I think it's important that we do research, and I'm going to give you a little bit of research. I don't want to snow you with data that almost no one understands, but just to give you a sense of what we're doing and what other people are doing. We hypothesize that SUDEP is caused by seizures starting in the cerebrum. That's that part of the brain above the brainstem and the cerebellum. So you got the back of your brain, which is the brainstem and the cerebellum, and the rest of the brain. And most seizures that we see in the clinic come from the cerebrum, come from the cerebral cortex or the temporal lobe, the mesiotemporal lobe. So typically, epilepsy in our patients and adults starts in the cortex or the temporal lobe or the hippocampus. And then when they get bad, they spread into the brainstem. So this we know already. This then causes, we think, cardiorespiratory failure. That's respiratory arrest followed by cardiac arrest and death. The centers for controlling the heart and the respiration are in the brainstem. So our hypothesis is that when generalized seizures get into the brainstem, they disrupt the cardiac center and respiratory center, particularly the respiratory center, causing the death. Just an overview of some experiments that are ongoing in my lab. We're sticking electrodes into the cortex, into the hippocampus, and into the brainstem, and we squirt a convulsant into the hippocampus. This is often where seizures start in adult patients. And we measure what the electrical spread of the seizure into the cortex and then into the brainstem. And this is the kind of recordings we get. Here you see a seizure starting in the hippocampus, and then it spreads to the cortex here. And here we're recording from the brainstem, and nothing happens of significance in the brainstem. And here we see that we're measuring at the same time, and this is a rat, the electrocardiogram and the respiratory rate. And we see that the electrocardiogram stays pretty stable, and the respiratory rate actually gets faster. Okay, now if things worsen and you get spread of the seizure, there's the seizure here in the hippocampus, and it spreads into the cortex and then into the brainstem, you get a different response of the respiration and the cardiac. The respiration becomes very slow and irregular, and the heart rate also becomes slower and irregular. And what we see actually in animals that die in this situation is they have a whole bunch of seizures, particularly in the brainstem, and then the seizures stop, the respiration stops, and then the heart stops. So at least we now have an animal model that we can study in depth to try and prevent this situation, and we already have some data on this, as well as many other labs. So brainstem seizures. So when the seizure activity spreads from the upper part of the brain, where seizures usually start, and gets into the brainstem, that can cause this respiratory depression followed by cardiac arrest, which seems to explain SUDEP in most patients. Hence, preventing brainstem seizures might prevent SUDEP, and we've done some studies already trying to prevent seizures in this situation with some success, and that the animals don't go on to have respiratory cardiac arrest. Now, what's the importance in humans? Brainstem seizures most likely exist in humans, explaining some of the features of epilepsy, which include stopping breathing, cardiac abnormalities, generalized tonic posturing. The trouble with brainstem seizures in humans is we can't measure them, because to stick an electrode into the brainstem is a very tricky business and can kill the person. So we just don't have recordings in humans from the brainstem. If some seizures emanate from the brainstem, they may not manifest in the scalp or even intracranial EEG. This talks about pseudo seizures. I'm sure you've all heard about pseudo seizures or non-epileptic seizures, where we bring patients in and record from their scalp the EEG, and we watch them have seizures. And sometimes we don't see any abnormal activity in the scalp EEG, despite the patient having a seizure. And often we call that a non-epileptic seizure because there's no simultaneous electrographic abnormalities. And often that is the case, and the patients have often what we think are psychogenic reasons, which doesn't diminish the importance of these seizures, but it certainly would suggest that giving anticonvulsants isn't going to work. On the other hand, some patients actually might have seizures that we just can't pick up from the scalp, particularly if they're deep in the brainstem. So Sudep appears to be a brainstem issue, and preventative measures need to be directed to that structure. And there's some evidence that certain drugs that enhance serotonergic activity, such as antidepressants, may prevent Sudep in animal models, and this has to be looked at in humans. The relevant pharmacology for Sudep may be different from what we know about supratentorial originating seizures. Saying there, the pharmacology for brainstem abnormalities may be different than the pharmacology for the cortex and the hippocampus. Now, one other thing is, I've been working with a colleague, Dr. Barish Bardakian, who's an engineer and biomedical engineer at the University of Toronto with some very gifted students. And we're trying to see if in EEGs of patients who went on to die from Sudep compared to EEGs of patients who have epilepsy but didn't die, was there anything that we could pick up that shows a difference? And in fact, we have picked up a biomarker, something buried in the EEG, which with signal processing we can see, which seems to quite strongly predict those patients who later died of Sudep compared to those who didn't. These are not features of any standard EEG report. You need fancy mathematical computational assessment of this EEG. So this is not something we can do today, but in the future, this might be an important biomarker predicting someone's risk for Sudep. And of course, there are ethical issues about knowing about this biomarker, so you would know, or patient would know, that they're much more likely to have Sudep. But certainly this is a very important feature that is being investigated now. So the biomarker, we need a much larger data set to see if it's reliable. We're also going to include cardiac measures and respiratory measures to make this biomarker even more powerful. When during development or evolution of a seizure does this biomarker present? Can this biomarker be prevented if we see it coming? Oops, sorry, my phone. Sorry. There's maybe genetic correlations to this biomarker, so we may be able to genetically predict which people with epilepsy have the greatest risk for a Sudep. We don't know the underlying pathophysiology in relationship to brainstem seizures. Can it be reversed, and can we prevent Sudep? Of course, this would be a major goal. And can home seizure monitoring devices, including a comfortable wireless EEG headset worn overnight, be used to predict and prevent or warn of impending seizures, or even trigger a stimulus that could prevent seizures or prevent Sudep as well. First of all, I want to stress that we have to tell patients that Sudep does exist and explain it. The pathogenesis is being understood. And in the future, in the very near future, we'll be able to have home monitoring devices worn at night with software to predict, warn, intervene, and possibly prevent deadly post-ictal apnea and cardiac arrest, or SUDEP. So this is just a cartoon of a device that you could wear. Well, they're probably much more comfortable, much more subtle, but this is something that I think will be happening within the next year or two. I'm hoping to do trials on this here of home monitoring devices, because now they can be wireless. You don't have to have wires all over the place. They can be wireless electrodes that will send the information to a nearby computer and to the web and to the cloud, and that can be analyzed in almost real time or real time to provide feedback. And we're thinking about feedback to prevent SUDEP, to prevent seizures. There's evidence now that music, that's music going through the ears, of course, which goes into the brainstem, might be one treatment. So there's a lot of potential hope out there to give a warning and do prevention for seizures. And not only do we have to, can we measure electricity, we can also measure heart rate, respiration, all kinds of things. So there's a lot of technology I think can be applied to this problem in the very near future. Other therapeutic targets also include all these biochemical pathways, vagal nerve stimulation, which we now use for intractable epilepsy in patients that are not operative candidates for resection, seems to prevent SUDEP or decrease the incidence of SUDEP. And cannabis might be another one that has effects. We found that it has effects on the serotonergic system. So actually, cannabis, which helps people sleep, some versions of it might help prevent SUDEP. That's it. Thank you very much. Any questions?
Thank you very much, Dr. Carlin. Don't worry, I'm getting your feedback. So I already have a question here. So I understand that in other jurisdictions, they use a SUDAP screening at the beginning of one's epilepsy appointment. Is this something that could or should be occurring in Canada? And if so, what should be included in the screening?
I have never seen this. I'd like to see what they use to screen. What I start with is I tell the patients about SUDEP before. I wouldn't screen them for SUDEP before I have a discussion with them about what it is. Personally, that would be my approach. But then to screen for SUDEP, I don't know what's meant by that. Although I would guess the like a comorbidities like mental health, alcohol use, sleep, that kind of thing.
Mm-hmm.
But
Okay,
it's an interesting idea.
but so there's no screening tool for SUDEP.
Not that I use and not that I know about, but I'm sure there are. If someone says they're out there, they're out there.
I don't know if the participant would like to say if there's a particular name of it. It's SUDAP screening. So I don't know what that looks like. I've never heard of it. But
I
it
haven't
could
either.
be
I
interesting.
think it's not a bad idea after you've had a discussion with the patient and the family about SUDEP and what it is.
I'm wondering, so the question I have is, I know there are a lot of devices out there to monitor seizures.
Mm-hmm.
Um, do you feel like those devices, like the persons who use these devices, do you find in your experience that they are less likely to have SUDAP?
First of all,
If,
I have very few, if any, patients who are taking these devices, using
oh,
them in my
really?
practice. So I don't have much information on that. Secondly, I think there's research ongoing right now with these devices to see if it prevents SUDEP. Thirdly, most of these devices, in fact, all of them do not involve recording as yet the EEG. They record your movements, the heart rate, etc., which can be useful to And the devices probably can tell you if you're having a seizure. Since Sudep usually occurs in bed at night, I don't know whether it's set up for working in bed at night with some sort of feedback, maybe a noise. So I think there's all good potential there for helping to decrease the incidence of Sudep, but I don't think the research is in yet.
Okay, because I know I have a few patients that they have devices that they use that really just says it tells them when they have seizures, like the length of time and so on. I'm assuming from what I got from them that it tells you about your heart rate and things like that. I
Yeah,
don't, yeah.
I think it's probably a good thing to have a device because then the patients can understand their seizures because often patients don't even know they're having seizures. So I think just to have a device that tells you you're having a seizure, then you can sort of understand your own epilepsy much better.
Yeah, I think so too, because I mean, as you were saying, a lot of people they're sleeping alone, right? Those persons who have
Yes,
died,
yes,
so of course, you see, they don't have someone there to monitor them. Anyway, it depends on the person that's sleeping next to them, and because some people sleep so soundly, I don't know that they'll be much help if the person is having a seizure next to them. But of course, I don't know. I just think it might be better for safety to have someone sleeping with them. Um,
yes.
yes. Are there any other questions? For Dr. Karen at this time. Um, and you would just feel free to type in the chat box and I will read the question out for him to respond. I think it's a golden opportunity to
Well, maybe
get as much.
maybe people could to tell us whether they have had a discussion of SUDEP with their healthcare provider.
Oh, that's interesting to know. For any of the participants, if, you can indicate by raise of hand or you can type in the chat box if you have already had a discussion with your service provider, your healthcare provider about SUDA. Anyone? And while I'm waiting to get a response, Dr. Karen, do you know if all of our neurologists at our clinic have a talk with their patients about SUDAP, or is it just you?
I think most of us now talk about SUDEP.
Oh,
Uh,
okay. Okay.
I don't know whether they do it in the first visit. I like to be pretty confident about the diagnosis of epilepsy before I talk about SUDEP, but it
Okay.
certainly something I must say many years ago when I understood it and I had one of my first patients that died of SUDEP. I was really very gratified that I had actually thought of telling the family, discussing it before, because it would have been extremely embarrassing to have someone pass away and not discuss it, not have them at least know that this is part of the problem of epilepsy.
Okay, someone types in chat box. I did not have successful removal of the left hippocampus. I spent 2 weeks back in the EMU and had an impaired focal for 7 hours and a tonic-clonic while there. Since then, I have had a tonic-clonic on full meds. What is the probability of SUDAP in my case?
Well, you certainly have active epilepsy, so it's more likely than someone who has very, very well controlled epilepsy. But again, fortunately, it's still not terribly common, but it's certainly something to keep in the back of your mind and try and mitigate other factors. So seizure control seems to be very important, but also emotional state, having someone around when you're sleeping. These are all other factors to help mitigate. And I hope in the near future that we'll have uh, other things like we may be able to put in music while you're sleeping that's appropriate, or we have a headset, an unobtrusive headset, which you can wear when you sleep. And when a seizure is predicted to occur or will occur, then some kind of auditory feedback could be presented. I think that's a real possibility in the near future.
Okay. Another question, are left temporal lobe seizures a risk for SUDEP? Also, is there a genetic link between siblings for SUDEP?
I think left temporal lobe or right temporal lobe are both risks. I don't know if there's a side preference. I'm sorry, just don't know. And I'm sure there's a genetic predisposition to Sudep. There are animal models showing that genetics can play a big role. So for sure, there's a genetic predisposition. And I think we just haven't worked that out yet, but there are a lot of people working on it.
Okay. You mentioned that VNS is one that is that VNS. Are you saying it's a prevent, like it would prevent SUDEP, or are you saying that
Well, the
it would
VNS
minimize?
company, which is very aggressive and very successful business, have analyzed the data of the patients who get VNS, I believe compared to similar patients who don't, and they find that the VNS patients have a lower incidence of SUDEP. And that might make sense. So those people who have epilepsy that's so bad that we can't treat with drugs or resective surgery and they get VNS, that's a good thing. And the other good thing about VNS is it seems to decrease depression.
Decrease depression, yes. Yes, I learned that recently in one of the in-service VNS education workshops, which is a good thing. Yeah,
Yes.
so because the reason I asked because I saw one of the participants, she was speaking about the amount of seizures she was having, and I don't know if she's if she might be a candidate for VNS. Would that be something she should discuss with her
Yes. Yeah. I
doctor?
mean, if surgery has failed, then certainly that's something to consider.
Okay, okay, yeah, because I guess it seems like a lot of I guess a lot of seizures and using
Yeah,
medication. Yeah.
I must say that initially I was very skeptical about VNS, but recently they've made changes to the stimulation paradigms. So I think it's a reasonable thing to do. And fortunately, in Canada, the costs are covered by the government because
Did
it's
you say
very
said fortunately the cost, so you don't have to pay for it, it's free, right?
no. They're fortunately the costs are covered in Canada.
Great, yes, yes. Yeah, and I know that the persons that assist with the VNS, I think it's the installation or education that come into our clinic, they are always there around for patients if they have questions too. So it's
Sure.
good for patients if they want to find out, I guess, what is VNS, and they might have been hearing about it. So that's good that at least we have them. I don't know if on our team are working with us. I know which would be the more appropriate terminology to say. Are they working with us or are they just part of the team? What is it, Dr. Carlin?
I'm
The
sorry.
VNS persons that come in that work in our clinic that come with the VNS to tell us about it and to have the patients learn about what VNS is
I don't
really.
know.
Are
I don't know the
part.
person, but I think that's a good idea to have a discussion on that, especially doing
Okay.
it. Yeah.
Any other questions? Uh, we have roughly 15 more minutes. So if you have any other questions, please feel free to type in the chat box at this time. Someone is writing. Okay.
Yes. Someone.
They're putting the website sudep.org talks about regular epilepsy risk reviews and the SUDEP and the seizure safety checklist. So I think this is they're sharing this information. Just FYI. Oh, this is from a UK site. Sudep.org talks about regular epilepsy risk reviews and a SUDEP and a seizure safety checklist. Oh, this is great.
Yeah. There's good stuff on the internet.
Yeah, I observed that the UK website for epilepsy, they have I don't know the exact name, but they have really good information on epilepsy and the epilepsy related challenges. Um, okay, what I'll do, anyone else with a question? I can just put the feedback form here in the meantime while persons are thinking about a question. We might end early today, Dr. Karen.
Oh, here's
Oh,
how
someone
to
has a
help with
question.
research. That's uh well of course, the most important thing is to, if there are studies ongoing about monitoring, which we're going to start hopefully in the next few months. That's all. It's very good that we need patients to participate in studies. Of course, fundraising is always a big headache when you're trying to do laboratory research. So if people can help there, that's nice. But I think being aware of it, telling other people with epilepsy about it, and participating in trials for monitoring devices and studies related to Sudep was very useful.
So if someone wants to participate,
Uh,
sorry, when
Here we
we
are.
lose,
When
yeah.
we lost it, we were asked. Yeah, I don't. The chat doesn't stay here. I'll show
Oh,
probably.
when we lost
Oh,
our
there we.
daughter, weren't asked to provide samples for research, how can this be changed?
You're asked. Wait a second. We were asked to provide samples. How can this be changed? What change would you would like? Um, I don't understand the question. You did
I
not
think
want to be asked, or was something wrong about how they asked?
so they think they weren't asked to provide samples for
Oh,
research.
weren't. I'm sorry. Weren't asked this. Oh, Sam. Oh, I'm sorry. Weren't. I'm sorry. I didn't read it right.
Yeah.
How can that be changed? First of all, if depends where your daughter died and circumstances and when. I mean, sometimes people
Toronto.
in Toronto. I'm sorry, I don't know. I presume there was an autopsy, but if there isn't an
Recently.
ongoing genetic study, then I guess no one has use for it. But there's now a lot more research going on in Sudep. So I would say if sadly someone passes away from Sudep, certainly the neurological caregiver should be notified, and that person, if there are ongoing studies, should be able to help.
So like
But
provide.
I don't even know now if someone's offering samples, I guess it would be from the autopsy. I don't think there's a study that I can think of locally that people are doing, although we do have an active epilepsy genetics program. So that's a great question and something I'll think about. It's a
Okay.
great question.
Yeah, because I guess if people
We
are
should
aware.
have a registry of anyone who dies from Sudep, both so that we can look at the EEGs, pre-death EEGs, and all the circumstances around to understand it better.
But there's no registry currently.
Not that I know of in
Oh,
Toronto.
yeah, so the person agrees, yes, we should have a registry.
Okay, there's a lay organization working on Sudep, mainly focused with children, but I think we should look into that. Yes, okay, thank you.
Yeah, that's a very, very good suggestion. Because that's way even for
I'll look into that.
yeah, Dr. Karen, even for your research, if you
Now
have
I
a
have
list of
homework.
people. Sorry? Oh yeah. Yes, you do. So
Good.
could you fill out the for the participants still here, could you fill out the feedback form? Your responses are very valuable. I've already added it to our chat. If you can fill that out. Any other questions, comments, suggestions?
Okay, I have epilepsy rounds coming up.
Okay. So I think we can close off early because I don't see anyone else typing a question here. Dr. Carlin, any closing words before?
No, thank you.
Close
I
it?
made you made me gave me homework and you made me think a bit more about it.
Yes.
And I hope I was able to illuminate a little bit this difficult area.
Yes. Thank you so much.